Good morning and good afternoon, CEoT. Today, CareDx brings to you a very exciting symposium on the latest in the AlloSure world, AlloSure surveillance and relative change value. I'm your session moderator for today. My name is Vinaya Rao, and I'm the medical director at MUSC, Medical University of South Carolina in Charleston. We have been using AlloSure very successfully at MUSC and have incorporated it into most of our patient care protocols. We currently are a part of the OKRA and the CEoT studies, and we also have an investigator-initiated trial ongoing at MUSC. I'm very excited and eager to learn more from the fantastic speakers we have today. The agenda will be as follows. Dr. Sanjeev Anand, baseline characteristics and relative change value of donor-derived cell-free DNA. Dr. Gaurav Gupta, ADMIRAL Study, assessing donor-derived cell-free DNA, monitoring insights of renal allografts with longitudinal surveillance. Dr. Nicole Ali, SARS-CoV-2 and renal transplantation, the NYU Langone experience. Dr. Hassan Fatah, AlloSure, relative change value in clinical practice. Dr. Arjun Jamali, AlloSure in kidney transplant recipients, 3 practical examples. Our first presenter is Dr. Sanjeev Anand. He comes to us from Intermountain Kidney Transplant Center, where he's the medical director of the Living Donor Program and the medical director of kidney transplant research. I'm sure he'll give us a very interesting talk on the baseline characteristics and relative change value of donor-derived cell-free CNA. So take it away, Dr. Anand. We are waiting to hear from you.
Transplant nephrologist at Intermountain Kidney Transplant Center, and I'm the medical director of Living Donor Program and also the Kidney Transplant Clinical Research. And today I'm going to be presenting on baseline characteristics and relative change value of donor-derived cell-free DNA. So, in the backgrounds, the limits and cutoffs of donor-derived cell-free DNA as an injury biomarker in kidney transplant have been largely based on coupled single event or biopsy measurements. So essentially, if you had a donor-derived cell-free DNA coupled with a biopsy measurement, that has been usually extrapolated from a single measurement to prospective repeat measures. Meaningful interpretations of repeat measures of donor-derived cell-free DNA at this time requires factors that determine biological variability, its time variance post-transplant, and its relationship to donor and recipient characteristics. So in this study, essentially, what we were interested to see was that if any of the factors, which is the donor and recipient characteristics and the time variance of donor-derived cell-free DNA post-transplants, and also if factors attributed to surgical issues like cold ischemia time or kidney length, if any of those did in fact impact donor-derived cell-free DNA. And the hypothesis was that incorporating knowledge of the above factors would refine the clinical utility of the use of donor-derived cell-free DNA. Some of the definitions that you can see on this slide is biological variation and relative change value. I want to emphasize on the relative change value because we're going to discuss this further down the road. That's a percentage change between 2 consecutive results in an individual, exceeding which that can be explained by biological variance alone. As explained before, the aim of this study was to report the impact of donor and recipient variables on donor-derived cell-free DNA in a population of clinically stable kidney transplant recipient, and to report biological variability of donor-derived cell-free DNA in real-world patient population. So we had a total of 125 patients who underwent kidney transplant and had serial donor-derived cell-free DNA samples obtained at 1, 2, 3, 4, 6, 9, and 12 months post-transplant as part of their standard of care. These patients were after excluding biopsy-proven acute rejection patients. So essentially, these patients were stable patients, and we also excluded patients who had CMV or BK viremia for calculating of RCV and coefficient of variation. This table summarizes the demographics and clinical characteristics of patients. As you can see, there were 125 patients, and the mean age of the patient was 52.6 years. 82% patients were male, and we had an even split between deceased donor and living donor kidney transplant. And I wanted to point out the median cell-free DNA at 1 month was 0.32. Now, coming to the results, first, what we're going to do is that we're going to look at donor-derived cell-free DNA at 1 month by kidney transplant type, and then we're going to look at by donor type. And then the second, we're going to look at the longitudinal variance of donor-derived cell-free DNA by transplant type and by donor type. In this slide, as you can see, on the x-axis is different kind of transplant. So you have the first one is the first kidney transplant, then you have the repeat transplant, and then the third one is 2-for-1 or dual kidney transplant. And this is median donor-derived cell-free DNA at first month. And as you can see that there is a significant difference between donor-derived cell-free DNA for first-time kidney transplant versus repeat kidney transplant. And there was also a higher value noted in 2-for-1 kidney transplant, but that did not reach statistical significance. Again, this is at 1 month. Now we are going to look at by donor type. So when we look at by donor type, we see this nice downward trend between different donor subgroups. So as you can see, the DCD had a higher median at 0.45. Then comes the donor after brain death, which was 0.37, then living unrelated, which was 0.34, and living related, which was 0.27. There's a significant difference when compared DCD versus living related, which was P was 0.036. Next, we come to the longitudinal repeated donor-derived cell-free DNA measurement, which also showed that there was a downward trend, and this is as per transplant type. So on the left box, we have the first kidney transplant. On the right box, we have the repeat kidney transplant. In the first kidney transplant, you can see that there was a statistically higher value at the first month, which kind of gets lower at the second month and subsequently further lower at 3 months. And on the repeat transplant, we don't see a statistical significance, but there is a downtrend from first month, second month onward at third month. Now, looking in the longitudinal, further we look at by various donor types. So on the left-hand upper corner, we have the DCD group, and on the right-hand upper corner, we have the donor after brain death. And then the left lower corner, we have the living unrelated, and the right lower corner, we have the living related. As you can see in the DCD category, on the first month, and each box by different color represents different time frame. So the first one, the blue box is first month, the red is second month, and the green is third month. As you can see, for all donor types except living related, there is a significant downward trend of donor-derived cell-free DNA, which is highest at first month and then subsequently downtrends at the second month and then subsequently at the third month, signifying that there is initially this ischemia reperfusion injury that kind of takes it a while to settle down and usually settles down by the second and third month. This is again essentially showing the same data, which actually includes all transplant, including the first transplant and the repeat transplant. And it shows the same values that we discussed in the previous slide. The second component, what we studied was relative change value. So we looked at relative change value if that relative change value that we calculated at 66%, does that increase our diagnostic test accuracy of donor-derived cell-free DNA in diagnosing rejection? On the left hand, you can see the ROC curve. when you use greater than 1% as your criteria for rejection. And on the right side, you can see the ROC curve when you use greater than 66% as your criteria for rejection. And these are all rejection, acute cellular and antibody-mediated rejection combined. And you can see in the specificity, sensitivity, and the positive predictive and the negative predictive value, when we use greater than 1% as the cutoff, then your positive predictive value is only 57%. But when you use 66%, which is the relative change value as your cutoff for rejection, then actually you increase your positive predictive value to 73%. This slide has a very important message, which means that actually we should not rely so much on single measurements, but rather it should be a serial change in donor-derived cell-free DNA that should further lead to evaluation and further therapeutic, and it has further therapeutic and diagnostic implications rather than a single derived cell-free DNA. So in summary, repeat transplant, dual kidney transplant were associated with a higher donor-derived cell-free DNA at 1 month. Also, certain donor types, like the deceased donor after cardiac death, was associated with higher median donor-derived cell-free DNA at 1 month. Hence, incorporating donor/recipient variables and time-down dependent evolution post-transplant is material for rational interpretation of donor-derived cell-free DNA cutoffs in clinical decision-making. Essentially, we should incorporate the donor and the recipient variables when trying to make a decision about a value of donor-derived cell-free DNA and its diagnostic implication. Also, one value should not guide decision-making, rather than a change in value should guide decision-making. And in the last slide, this again shows, this is from Eric Steit's data. This essentially shows that donor-derived cell-free DNA is essentially kind of a continuum. So that 0.21 value, you have this 95% negative predictive value for acute rejection. And as you go higher on the continuum, and higher values are associated with more rejection and more graft loss. Thank you, everyone, for your attention, and I will welcome question and answers after the session.
Thank you, Dr. Anand. That was a great presentation. Very interesting to see your data, your center's data on longitudinal surveillance, and especially the relative change value. Now on to our next speaker, Dr. Gaurav Gupta. Dr. Gupta and I go back several years. We unsuccessfully tried to recruit him from Johns Hopkins. It was VCU's gain and our loss. But Dr. Gupta, good to see you again, virtually, and waiting to hear your talk.
Good morning, good afternoon, good evening, wherever you are. Thank you for the opportunity to present this data. So I'm going to present the ADMIRAL study that looks at the impact of serial measurements of donor-derived cell-free DNA using AlloSure in kidney transplants. And this is actually the first study to do so. So I'll start with some background here. I think at this point there's substantial evidence to suggest that chronic inflammation is associated with an increased risk of mortality, both in patients on dialysis as well as those with kidney transplants. Similarly, it also makes biological sense that inflammation drives formation of donor-specific antibody, or DSA, proteinuria, loss of kidney function, and eventually graft loss. So can we find biomarkers that may assist us in detecting inflammation? And as can be imagined, that inflammation can drive increased cell breakdown, and thus an increase in measurable cell-free DNA. In addition, it is also possible that donor-derived cell-free DNA itself acts to drive up allo responses. So based upon previous studies, we now know that ddcfDNA, or in this case AlloSure, can be used to detect rejection. But in this study, we wanted to go further and ask the question whether AlloSure may serve as an early marker of inflammation or injury, before the development of DSA and loss of kidney function. So this was a multi-center study that included 7 large US-based kidney transplant centers, and nearly 1,100 patients were enrolled. And we looked at several outcomes. We looked at the correlation of AlloSure surveillance and formation of de novo DSA. We also looked at the correlation of serial AlloSure changes and kidney function as measured by GFR. In a subset of nearly half the patients, we also looked at those with a measurement of DNA and graft injury as well as rejection. With regards to the biopsies included in the study, after careful data curation, 219 biopsies were included in the final data set, of which 107 had rejection. Of these with rejection, 2/3 had antibody-mediated rejection, and nearly 1/3 had T-cell-mediated rejection, while the remainder had no rejection. So here we validate the findings of the previously published DART study and report that the findings were fairly similar. The EUC curve for all rejection episodes here was 0.77, and this was slightly higher for ABMR and slightly lower for TCMR, similar to the DART study. But what's new now is that we can report that even among surveillance biopsies, AlloSure is able to predict rejection. Once again, these numbers do suggest that cfDNA elevation is higher in ABMR than in TCMR. But the median cfDNA for either ABMR or TCMR is higher than no rejection cases, as can be seen here, indicating that a discrimination ability is clearly preserved above a cutoff of more than 0.5% for the prediction of rejection. So I want to now move away from a discussion about cfDNA as a diagnostic test for rejection and start thinking about it as a marker of injury, and then share some data with you about how we can support that association. So what was done here was to look at the presence of any injury based upon a composite of development of de novo DSA, acute tubular injury, BK virus, or rejection. And we compared AlloSure in these patients to those without any obvious injury, which was defined as graft quiescence. Patients with injury had an almost 2-fold higher median AlloSure at around 0.5 compared to those in a quiescent state. So this next analysis utilizes an unsupervised machine learning algorithm called k-means clustering to group serial patient measurements, which can be seen here in the middle blue bar, from multiple patients into coherent clusters that may behave in a similar fashion. Based upon these measurements and methodology, 4 clusters were identified in the study. So this analysis reveals a cluster where you can see a slight negative correlation between kidney function, GFR, and AlloSure at 1 year that becomes much more pronounced by the end of 3 years post-transplant. So we then looked at the impact of AlloSure measurements on formation of de novo donor-specific antibody. On an average, AlloSure measurements were taken around 6 months prior to DSA measurements. Of a total of 961 patients, 44 developed de novo DSA. And what can be seen in this graph is that patients with an AlloSure of 0.5% or higher had a nearly 2.5-fold higher risk of DNDSA formation. Finally, previous studies have excluded patients with previous failed kidney transplants. ADMIRAL, on the other hand, included 60 retransplant patients. What you can see here is that these patients had a slightly higher baseline AlloSure than de novo transplants. But the performance characteristics with regards to rejection for these patients was similar to de novo patients, although that slide is not shown here. So in summary, ADMIRAL identifies that a value of more than 0.5% can discriminate rejection from no rejection. A relative change of more than 150% from baseline in patients with serial measurements had a strong association with rejection. AlloSure is a marker of injury, and stable low values may indicate immune quiescence. On the other hand, escalating values were associated with a loss of kidney function over time. And finally, Elevated AlloSure precedes TNDSA formation, suggesting an association with early injury that may have triggered the alloimmune response. And with that, I'll end. Thank you for your attention.
That was great, Dr. Gupta. Fascinating to see the correlation between, AlloSure and donor-derived DNA, and of course, EGFR decline. And I think what's most interesting is how you've incorporated machine learning algorithms into your analysis. That is, of course, the future, and this is a great start. Thank you again. Our next speaker is Dr. Nicole Ali, coming to us from the NYU Transplant Center. Dr. Ali will be sharing with us today their very valuable SARS-CoV and renal transplantation experience. As we all know, they were the pioneers in this fight with COVID, and we're all waiting to hear and learn from your experience. Dr. Ali?
Hi, thanks for having me. So I am Nicole Ali. I'm the transplant nephrologist and medical director of the kidney transplant and pancreas transplant program here at NYU Langone. And today I'll be sharing with you a little bit on our experience with COVID-19 and our transplant patients. So first, of course, very early in 2020, some very devastating forces aligned here in New York, and we had rapid escalation of infection rates with a significant demand on our hospital services. With this state of emergency that was declared also in March, we found that our services were very overwhelmed. We had excessive deaths associated with COVID-19, with the highest peak between March and May of 2019. Mortality rates associated with COVID-19 in our renal transplant patients have been reported to be anywhere between 10 and 25% across individual centers in New York. I think more of that data is available now, and most people would agree the mortality rate is somewhere in the 20% amongst the immunosuppressed population. In terms of the impact that this had on our transplant program, from mid-March until mid-May, we did not do any transplants. We do living donor, deceased donor transplants in the kidney program. We also have a liver, lung, and heart transplant program and a very large bone marrow transplant program. Organ transplantations went to a halt across all of those programs, mainly driven by the lack of organs and the lack of beds for patients. We did keep some patients active on the waiting list who were willing to be transplanted. But in effect, there was really nothing going on in terms of transplantation at our program during that time. We did resume transplanting in mid-May, and our first transplant back was a living donor transplant, and shortly thereafter, deceased donor transplants started coming in as well. Like I said, on our waiting list, our highly sensitized patients did remain active. Some of them chose to be inactive. There were many patients who were concerned about getting transplanted during the peak of COVID, and so they chose to be inactive. But we did feel that keeping the highly sensitized population active was important, as they have very little opportunity otherwise to get transplanted. In the beginning peak of our COVID experience, we had over 100 patients get infected with COVID-19. And unfortunately, more recently, we have started to have our patients impacted again by the second wave of COVID-19. We had 74 kidney transplant patients that were infected, one of them being a pancreas after kidney, 18 liver transplants, 11 lung transplant patients, 11 heart transplant patients, and 5 lung transplant patients. We did maintain our outpatient clinics open through all of this. However, very much we shifted to telemedicine very quickly as much as patients were able to. Urgent visits were continued in the outpatient office. Leading up to March, our months of transplant in June and in January and February and the beginning of March were very busy with deceased donor transplants. So we did have a lot of fresh transplant patients who required surgical care, and they came to the office for that. Otherwise, anyone who did not have an operative issue or have a wound that needed to be looked at did telemedicine, and we were able to onboard all of our physicians and advanced providers and put a lot of effort into getting patients up on MyChart almost overnight so that we could safely take care of our patients with telemedicine care. In addition, I'll talk later about our experience with remote blood draws that also helped a lot of our patients remain safe. In terms of research, we have a very large research enterprise within the Transplant Institute at NYU, and research that was non-SARS-CoV-2 involved was paused at the time. That recommenced in June of 2020, but very rapidly our research team shifted to COVID-19 related trials, interleukin-6 inhibitor trials. We had a trial run by Dr. Lonzi, one of our transplant surgeons, that originally that drug was intended to look at treatment for antibody-mediated rejection and potentially desensitization, and that was quickly pivoted by our research team led by Dr. Lonzi into a COVID-19 clinical trial. In terms of how we returned to transplantation, we really spent a lot of time with our directors and our leadership creating COVID-19 negative pathways, ensuring that we had ways for our patients to remain safe in the hospital, for the pathway from their admission to their hospitalization, including the OR staff, the OR transport, the staff on the floor were all screened for COVID-19, and that we ensure that there was separation between the COVID-positive patients and the COVID-negative patients. We did a lot of counseling of patients in terms of the risks and benefits and what sort of precautions to take inside and outside of the hospital. Initially, visitation was limited as it was in many hospitals. We have now started to allow one visitor per patient in limited visitation hours, of course with restrictions of masking and screening at the front of any fevers or symptoms of COVID-19. Our living donor program, we do screen all donors and all patients who come into the clinic for symptoms. Our living donors are also screened with IgG for COVID-19 at their evaluation visit, and we do focus on counseling the donor regarding potential risks, including the need for precautions and isolation, quarantining to take place before their donation, because as we all know, while PCR testing is very helpful, it is not 100%. And so within the windows that are currently in place, we need to also ensure people are taking precautions to prevent transmission to recipients. We do have 2 screening points prior to surgery, 72 hours prior to a living donor surgery and 24 hours prior to the transplant for the patient's both donor and recipient to get screened with a nasal PCR. In the deceased donor program, of course, we don't have the benefit of time in terms of screening patients, so we do screen them all with a nasal PCR on the rapid platform, and that's about a 45-minute turnaround time, and that's done on admission for deceased donor transplant. We do screen all of our patients who are active on the waiting list. We screened at one point with COVID-19 IgG when we were reactivating patients, and we do screen all of our evaluation patients. However, we realize that there's much time between you being placed on the list and your transplant, so there will be some patients who get sick along the way, and we've had a number of patients who we've had to update or inactivate because of new infection and then reactivate them once they're over that. Currently, our transplant volume is back to pre-pandemic areas and then some. We actually exceeded our volume of transplants in the Institute this past month. It's our highest volume of transplants ever in the Institute. And that's great. It means that people are back to wanting their transplants. Organ volume is back. Organ availability is back. And we are really happy with the pathways that we've outlined. We've tested them. We've not had any transmission of COVID-19 on the transplant floor or within the hospital with our patients. And we continue to encourage them to get vaccinated, but also to continue their precautions because, of course, every point is a risk point. We did initially adjust our induction immunosuppression regimen to use less interleukin-6 inhibitors. We have now gone back to our pre-pandemic induction regimen protocol. And we continue to do telemedicine and mobile phlebotomy for many of our patients. Our telehealth visits immediately after post-op, after their post-op needs are addressed, continues. Most of our patients are seen on that platform, including with translators, and we do have a lot of patients who need interpreters. Our mobile phlebotomy team has been absolutely tremendous. We have over 250 patients who are currently getting home phlebotomy, and that has helped a lot of our patients remain out of the hospital even when the second peak of COVID hit New York and numbers went up into the close to 10% rate of positivity, we were able to keep our patients pretty safe at their houses. In terms of antibody screening in our patients who did get COVID-19, about 80% of those patients mounted antibodies, so that mirrors the general population. I have a couple of cases I'll share with you about how we've managed immunosuppression during some of these patients who got COVID infected. So, of course, this is a challenge everywhere, and we're not sure we have the right answer, but it was important to us that we create some sort of streamlined process so that we were all practicing the same. We have 5 different transplant nephrologists, 7 transplant surgeons, and of course many different floors to which the patients get admitted when the transplant floor exceeds capacity. So we designed this approach using AlloSure cell-free DNA in order to help us modulate the immunosuppression, or at least see where the patient was in their course. So for all patients, either at diagnosis usually or at minimum on discharge, get an AlloSure score sent. For us, many of the patients do get adjustment of their antimetabolite, typically myfortic or CELSEP, during the acute infection. Some patients we will drop by 50%. Many patients we will stop the myfortic temporarily. And then we will reintroduce it sort of on an incremental every 2-week basis, but monitoring the AlloSure score test along the way. If their AlloSure score remains low, then we continue to increase immunosuppression just every 2 weeks. But if their AlloSure score increases rapidly or goes above 1%, then we do resume their full baseline immunosuppression, assuming the patient is recovered and feeling well. And so I'll share with you how that has happened with a couple of cases. So this first patient is a 45-year-old who got a deceased donor kidney transplant in August of 2019. Her post-transplant course was complicated by BK nephropathy, but she otherwise did very well. I put myfortic and Arava in here because there was a point at which she was transitioned from CELSEP to Arava. Her baseline creatinine was 1.5. Unfortunately, in April of 2020, she developed fevers, myalgias, and was subsequently diagnosed with COVID-19, as her sister, who's a nurse, also developed COVID-19. While the patient's PCR was pending, we checked on her every day with phone calls, and that's something that we standardly do for all of our COVID symptomatic or potentially COVID-positive patients. We will call them every day for 14 days. Many people, unfortunately, do have progression of their symptoms and end up getting admitted in that time, and we use the standard template for the calls the questions that they're asked, so we're able to compare day to day whether their symptoms have progressed, regardless of what nurse or nurse practitioner is calling the patients. So by day 5 of her call, she developed diarrhea, fever, shortness of breath, and had to be admitted to the hospital. At that point, she had acute renal failure with a creatinine of 2.6. and bilateral infiltrates on her chest x-ray. Her immunosuppression regimen was titrated with her CELSEP being held. Her tacrolimus and prednisone were continued with gold tacrolimus level of 4 to 6, and we monitored her through the hospital stay. This graph on the side shows you her inflammatory markers as she rode through the post-admission days. They peaked, her CRP peaked up in the 200s, as did her ferritin, and then after treatment started to come down. Her interleukin-6 level was also quite high, close to 600, and once she did improve, she was discharged back on leflunomide with TAC and prednisone instead of CELSEP. We did monitor AlloSure levels on her, so her discharge AlloSure was just about at 1, and then through the subsequent checks, her numbers went up. Unfortunately, we were still on the tail end of COVID in the hospital, and her kidney biopsy was delayed. By the time we got her in for a kidney biopsy, her AlloSure score had gone up quite high into the 7 range, and that biopsy showed cellular and antibody-mediated rejection. With treatment of that with steroids, plasmapheresis, standard treatment, we see here that her AlloSure score has come down quite nicely, and it's now finally below 1. Her creatinine has actually also improved very well as her AlloSure score has improved with the treatment that we've given her. So, in this case, maybe were it not for the pandemic circumstances, an earlier biopsy may have helped us to identify that something was going on with this patient, and maybe we could have modulated that more easily. In the next case I'll share, this is a 37-year-old who got a living donor transplant in May of 2018, followed by a pancreas after kidney in May of 2019. He had a relatively smooth course in terms of rejection, but he did have CMV viremia, which resolved relatively quickly after his pancreas transplant. In March of 2020, during a routine telehealth visit, he mentioned that he had some cough, rhinorrhea, and low-grade fever. This was very much early on in the pandemic. Testing patients was not widespread. The availability of testing, was pretty limited at this time. And, he is someone who had some risk, where 2 residents that live on site were positive, but he felt he did not have any direct contact with them, so he wanted to really remain at home. Again, into his daily calls, we found that he progressed his symptoms and ended up getting admitted with fevers and, ultimately had 10 days of high-grade fever in his hospital course. At that time, we were still treating with Plaquenil, which we no longer do, but that was what was being done at the time. So we treated him with Plaquenil. We gave him a course of azithromycin, and we saw here, his inflammatory markers were quite elevated. We were very concerned about reducing immunosuppression in this patient, so we did reduce his immunosuppression just a bit. We cut his tacrolimus down in half to a goal of about 4 to 6. We decreased his CELSEP down by 50% rather than stopping it completely, because he was a pancreas transplant patient, and as you all know, those are more prone to rejection. It remains the question whether reducing immunosuppression really has any impact in terms of the clinical course of COVID-19 in transplant patients. Is it the right thing to do? Does it increase their risk of rejection by doing so? And at what point do you increase the immunosuppression back to where you started? So in this case, we really had no answers to any of that, as most of us still don't have answers to that, so we used AlloSure to try to help guide us. In this particular patient, at the beginning of his course, his AlloSure score was pretty low at 0.18. However, once we had cut down his myfortic and his CELSEP, about 2 weeks later, when he was feeling better, his AlloSure score had taken a very rapid increase in this 2-week span of time, up to 0.9. Now, per our algorithm, we would have waited another 2 weeks before reinstituting any immunosuppression and another 2 weeks before we got back up to full dose. However, with this rather large increase in the AlloSure, we decided to up-titrate to full immunosuppression at this point, which meant 1 gram of CELSEP twice a day and running his tacrolimus levels at 8 to 10. With doing that, we see his AlloSure score came down nicely. He never had hyperglycemia or acute renal failure in this course, and he has settled out, pretty unremarkably to where he was before. So this, I think, is one example, again, of how we can use some of these newer markers to help us track patients in whom we're reducing immunosuppression and hopefully try to prevent rejection. The last case I'll share with you is a 60-year-old who was on dialysis due to hypertension and diabetes and got a deceased donor kidney transplant in September of 2020. He was treated with thymoglobulin induction and did have some delayed graft function, however, recovered his graft function just after 1 week of dialysis. His creatinine improved to 1.75. Unfortunately, a month later, he presented with lower back pain, poor appetite, and fever of 102, and some dyspnea. He was found to be SARS-CoV-2 positive. 1 month after transplant, this is very concerning. He'd gotten thymoglobulin. He was just a fresh transplant patient. These are the patients that, in our experience, did not do very well. So we were very aggressive. We initially, admitted him right away, found that his chest x-ray had bilateral pneumonia. His inflammatory markers, as you can see here on the side, were very, very elevated. And by this point, we did have access to remdesivir and to convalescent plasma. So with that, we felt confident that we didn't need to stop his I wouldn't say confident. We hoped that we would be able to treat him without completely stopping his immunosuppression. But as we all know, we do these things and we are not really sure how they're going to turn out until time passes. So we halved his immunosuppression, treated him with remdesivir and convalescent plasma, and saw that he did improve clinically and that his markers improved as well. Now, we had this cessation of, or cutting down of his initial immunosuppression pretty early on in his course. His AlloSure, after he was discharged from the hospital, was already up at 2.2. That was the AlloSure on the day of discharge. So at that point, we were very concerned that with just a couple of, maybe about a week and a half of holding, of giving him less immunosuppression, we had a pretty high AlloSure that we were starting off with. So since he was feeling well, we reinstituted his full immunosuppression regimen of full dose CELCEP, 1 gram twice a day, and running his tacrolimus 8 to 10. And we see here pretty quickly he had improvement in his AlloSure scores. His creatinine actually never bumped up, and he's remained completely asymptomatic since his recovery, since his discharge. So with those cases, this is just an idea of the framework that we use here for managing when we reduce immunosuppression in the setting of COVID. I hope that this has helped you some, and I encourage you to reach out to me if you have any questions in the future. I may not have great answers, but I can share with you what we do here at NYU Langone.
Thank you, Dr. Ali, and congratulations to you and your team for being pioneers in this fight against COVID in relation to renal transplantation. That was great. Our next speaker, Dr. Hassan Fatah, comes to us from University of Kentucky. Dr. Fatah is going to share with us today their center's experiences with clinical cases, real-world clinical cases that have a focus on relative change value.
Hello, everyone. My name is Dr. Hassan Fatah from University of Kentucky. I am very pleased and excited to share with you interesting cases that we have been following up here at the University of Kentucky. Case number 1, 28 years old, white female with CKD5 who received preemptive kidney transplant in May 2020. She was not sensitized with calculated PRA of 21%, received traditional induction immunosuppression with thymoglobulin solimedrol, followed by triple immunosuppression maintenance treatment with tacrolimus. Trough level in her case was fluctuating from 2 to 9. She was on and off CELCEP due to severe neutropenia. We do follow up every patient after transplant with a series of AlloSure following transplant. In her case, this is her results from baseline of 0.18. Our second test showed significant rise in her AlloSure from 0.18 to 0.9%. As part of our practice, we do follow up any rise in AlloSure of more than 61% from prior samples. We check for donor-specific antibodies against HLA. In this case, patient had what seems to be like low-grade de novo DSA against A2, as shown in this report. This diagram will summarize her post-transplant creatinine amongst other parameters following transplant. But creatinine was very close to baseline, which is 1.2 from post-transplant until most recent visits, with AlloSure a baseline of 0.18%. During this time, she was on and off CELCEP due to severe neutropenia with what seems to be a pretty fluctuating TAC level from undetectable to 9. Follow-up AlloSure showed significant rise from 0.1 to 0.9%, with later detection of low-grade de novo DSA. At this time, patient was opted to have only her immunosuppression maintenance maximized due to her decline to do kidney biopsy and the fact that she lives far away from our transplant center. So we did maximize her baseline immunosuppression, resumed her CELCEP, and kept her TAC level to at least 6 to 8. And her follow-up AlloSure showed significant decline in her value from 0.9% to 0.3%, with almost disappearance of her donor-specific antibodies. This is her follow-up AlloSure since the time she was kept on maximized immunosuppression to the most recent visit, which showed almost declining of her AlloSure to the pre-diagnosis value. And this is her most recent follow-up HLA report, which showed absence of A2 antibodies. So a few things that we've learned from this case and other similar cases. We might all agree that elevated AlloSure above 1% or significant rise in creatinine more than 0.3 or more than 25% from baseline is significant and prompt kidney biopsy as a second test. However, what to do for patients who have absolutely stable clinical course after transplant, who are otherwise unsensitized, like this patient? We've learned that mild rise in AlloSure is very sensitive in these cases, even though they have normal baseline labs. AlloSure itself is very sensitive to subclinical inflammation, and it might take us on maximizing immunosuppression in these particular patients to prevent any further damage or any further inflammation to the kidney graft. And that's what happened in this case and many other similar cases. The point that needs to highlight here is follow up with AlloSure as a diagnostic tool in particular patients, selective patients, might be sufficient to adjust immunosuppression and prevent any progression of graft damage, especially if this is interpreted in the right clinical context. Like in this patient who is young, under immunosuppressed because of severe neutropenia. We'd expect subclinical inflammation. In other words, subclinical inflammation is not unexpected in this particular patient. And this is reflected by rising in her AlloSure for more than 60% from her prior samples. We do know these patients who are under immunosuppressed, especially young ones, are at risk for alloimmunization, especially who are not exposed to enough PAC level of cells that are at higher risk for alloimmunization and formation of de novo DSA. Second case is very similar, 29 years old African-American female with a diagnosis of end-stage renal disease and type 1 diabetes, who received living unrelated kidney transplant in December 2019. She was not sensitized, was calculated PRE of 0%, received induction immunosuppression with a thimerglobulin salmeterol, and was kept on traditional triple immunosuppression TAC, myfortic of 360 twice a day, which was reduced later because of, again, neutropenia and daily prednisone. This is her screening sheet for AlloSure, baseline of undetectable level, with what seems to be a significant rise from her prior samples to 0.4% in June. For different reasons, patients did not follow up for this result. So we ended up seeing her in September when the repeated AlloSure showed further increase in her value from 0.4% to 5.6%. At that time, patient was brought to our center and she underwent a kidney biopsy. This is her HLA report, which basically was negative. And this slide summarizes her post-transplant creatinine amongst other parameters. So baseline creatinine was never changed from baseline, which is 1 from post-transplant value. During most of the time, she was kept on myfortic. 180 to 360 BID depends on how bad her neutropenia was. TAC level most of the time fell between 5 to 10. AlloSure, at the time when she was brought in here for kidney biopsy, for the concern of ongoing rejection, at least since May, when the first AlloSure showed increase to 0.4%. And unfortunately, our suspicions were confirmed with kidney biopsy showing mixed rejection for acute T-cell mediated rejection and chronic active antibodies mediated rejection, even though she did not have significant DSA. So in other words, she did have non-DSA or DSA negative, C4D negative, chronic active antibodies mediated rejection. She received treatment with steroid IVIG apheresis, and her follow-up AlloSure showed significant decline in the value from 5.6% to 0.6%, which probably indicates a significant resolution of her graft inflammation. Unfortunately, patient's treatment was interrupted during this time because of her being infected with COVID-19 and hospitalized at least 2 weeks with significant symptoms. Lucky for her, she never needed ventilation, However, her follow-up with AlloSure showed a significant rebound of her value to 2.4%. So a few points to conclude from the second case. Although we do not have enough data to support or to explain the dynamics of AlloSure post-transplant or post-treatment of rejection, however, we do know AlloSure is a pretty sensitive marker for subclinical inflammation. So it's easy for me right now to say retrospectively, if we catch this case like at the time where AlloSure was up to 0.4%, we could have prevented her to progress into chronic active antibody-mediated rejection. And again, this is retrospective view, and this might not be accurate. The bottom line is, as we all know, any relative change, even in patients with stable baseline creatinine, no proteinuria, no DSA, any significant rise in AlloSure for more than 61% from prior samples, probably exceed the biologicals and lab variabilities observed in reference population. Third case, I will switch gears here and move to other cause of AKI other than rejection. 7-year-old white female with ESRD unclear etiology who received deceased donor kidney transplant early 2020. She's not sensitized and received a traditional treatment that we do here at our center. This is her post-transplant creatinine values. At the time when her creatinine was close to baseline, which was 1.5, in April, she was diagnosed with BK viremia. She was treated with reduction of her anti-metabolite 50% down and keeping her TAC level close to 4 to 6. And during this time, her creatinine started going up. So, in midsummer, in July, her creatinine, AlloSure, and BK viremia level have all increased, which prompted her to do kidney biopsy, which came back confirmative for BK nephritis class 2, with no evidence of microvascular inflammation. Patient was treated with different protocols. She was converted eventually to cyclosporin, taken off completely anti-metabolite, kept on IVIG with subsequent resolution of her BK viremia and AlloSure. Both of AlloSure and viremia went down, while the creatinine remains about the same, which indicates significant background fibrosis in her biopsy. This is her HLA report, which came back negative. And this is her follow-up sheet for AlloSure. I mean, as you can see, it takes the shape of normal distribution with baseline AlloSure of 0.2, slightly increasing to the peak of 0.8 at the time when her creatinine started going up, and along with BK viremia levels. Kidney biopsy came back confirmative for BK nephritis from BK, and follow-up treatment showed significant resolution of her BK viremia and declining of her AlloSure to almost undetectable level. Last slide summarizes all this data together. As a matter of fact, summarize only the 2 parameters: the AlloSure results, which are represented in the red squares, and the BK in the blue line. And as you can see, there's almost concomitant rise and decline of both of AlloSure and BK PCR viremia. This case conclusions, few things that we might learn from similar cases where AlloSure might be useful as an adjunctive diagnostic tool in patients who are diagnosed with BK viremia. We do have data to support the use of AlloSure or the importance of AlloSure as a non-invasive test to assess the progression from BK viremia to BK viremia-associated nephropathy, like what happened in this case. And yes, maybe we do not have data to discern whether rising AlloSure in this case is related to rejection because of immunosuppression or because of progression to BK nephritis. But overall, this is another way where we can use AlloSure in this particular patient. Thank you.
Thank you, Dr. Fatah. This was very helpful. And once again, it reiterates, what all of us have been seeing with how important the relative change value is in clinical practice. And last but not least, Dr. Arjun Jamali. Dr. Jamali needs no introduction. He and I go back. I won't date ourselves by telling you how many years we go back, but we were fellows together at Wisconsin. It's an honor, and I'm very happy to welcome Dr. Arjun Jamali.
Hello, everyone. I would like to thank the organizers and CareDx for inviting me to present three practical examples of AlloSure utilization in kidney transplant recipients. This is my disclosure slide with affiliations with CSL Behring and CareDx and Takeda. This is the first case I was hoping to share with you, a case in which we use AlloSure in patients with CMV infection, 56-year-old secondary kidney transplant recipient with FSGS, CMV donor recipient positive and negative, underwent desensitization at the time of transplant with thymoglobulin plasma exchange, for a high CPRA, a positive virtual cross match, as you can see here, maintenance immunosuppression standard with tacrolimus, mycophenolate, and prednisone, who presented with a high CMV viral load of 830,000 copies per mil in an outpatient, from an outpatient laboratory 3 months after transplant. Here in this table, you see the different biological variables that were determined at this 3-month visit when he came to our clinic. Serum creatinine was at its baseline of 1.5. Viral load was confirmed at 830,000. Donor-derived cell-free DNA or AlloSure was low. We determined on a kidney transplant biopsy that there was no evidence of rejection because he was sensitized, and we were planning to reduce immunosuppression quite significantly. As you can see here, we stopped mycophenolate, cut tacrolimus by 50%, and treated him with IV ganciclovir, which we later switched to foscarnet because of drug resistance. At 6 months, serum creatinine had remained stable. CMV viral load had declined significantly. We, at this point, determined that he had circulating AT1 receptor antibodies because his donor-derived cell-free DNA AlloSure was elevated at 6.8%. We wanted to wait for the biopsy, but when we saw that he had AT1 receptor antibodies, we did a biopsy, which showed that the patient had antibody-mediated rejection with G1 PTC 3 lesions. Tacrolimus level was low, of course, because it was planned. Treated the patient with pulse steroids, IVIG, and the addition of losartan. Now, 12 months later, serum creatinine unchanged, still very low viral load, asymptomatic. AlloSure levels declined to 4.2%, but still above the standard 1%. Follow-up biopsy showed persistent antibody-mediated rejection with G2 PTC2 lesions. Patient received another pulse steroid cycle with IVIG. 3 months later, serum creatinine again stable at 1.5. We are fortunate that CMV viral load was now at 0. Circulating antibody levels were declining, as was AlloSure level, but at this point, still positive at 2.3%, undergoing a biopsy, which showed T-cell mediated rejection, T3I3 lesions. Patient underwent another round of pulse steroids and IVIG. So this is a very complex patient. I don't anticipate that we or others will see this kind of complicated cases frequently, but it clearly shows us the value of AlloSure in monitoring allograft pathology and health overall in a complex case of drug-resistant CMV, which was subsequently complicated with not only antibody-mediated rejection, but also T-cell mediated rejection despite normal graft function. The next case I was going to present is a more straightforward case, but a case of an AlloSure utilization in a high immunological risk patient. This one is a 47-year-old gentleman with a history of hypertension who also receives a second deceased donor transplant, highly sensitized with the baseline CPRA of 99%, positive virtual cross-match, and DSA against class 1 at 5,000, class 2 at 3,000, undergoing desensitization with thymoglobulin, plasma exchange IVIG, and discharge on triple immunosuppression with TAC, mycophenolate, and prednisone. At the 3-month protocol biopsy, because it's sensitized, serum creatinine again is at baseline, DSA are elevated, AlloSure is elevated, and the biopsy shows mixed rejection with I1, G1, PTC2, C4D3 lesions. Again, despite normal creatinine, in the presence of high AlloSure and antibody levels, patient undergoes intensive therapy with plasma exchange, IVIG, rituximab, and steroids. At the 6 months follow-up biopsy, serum creatinine is still baseline, and DSA have declined quite significantly with that management. AlloSure level has remained stable, and biopsy is showing this time just ABMR and no T-cell mediated rejection. At this stage, we treated him with steroids and IVIG alone. And this patient as well, now is about 12 months after transplant. He's doing well. Baseline creatinine is still at 1.2. So it's a case that illustrates the value of AlloSure in monitoring graft pathology in a patient that's a high immunological risk for rejection and has stable graft function. The third and last case is a case in which we used a relative change value for AlloSure to monitor kidney allograft pathology or health. It's a case of a 47-year-old patient with lupus nephritis that also was highly sensitized with a PRA of 99%, received a positive virtual cross-match kidney transplant with an MFI sum of around 1,000 that underwent desensitization with plasma exchange and IVIG, again, thymoglobulin and induction and maintenance therapy with triple immunosuppression. Now, this was a KDPI of 83%. The patient developed delayed graft function, but recovered with baseline creatinine of around 2. So at 3 weeks post-transplant, we performed a kidney transplant biopsy because of delayed graft function and highly sensitized background. Serum creatinine was at baseline, still had DSA, donor-derived cell-free DNA was, or AlloSure was normal. Biopsy was not showing any sign or evidence of a rejection. But 35 days after transplant, we had noted a rise in AlloSure level by more than 60%. The DSA was still present, although maybe at a slightly lower level, and creatinine was normal at baseline. Biopsy here showed subclinical rejection of G1 and PTC1. So confirming the value of a relative change in percentages of AlloSure readings in a high immunological risk patient as an indicator of a subclinical rejection. So in these 3 cases, I hope I was able to illustrate for you the value of AlloSure monitoring in some high-risk category patients that are immunologically unstable because they have CMV infection, that have a high immunological risk because they have a positive virtual cross-match and CPRA, or that there are patients that are undergoing a change in the relative value of AlloSure. Maybe AlloSure is not for all patients, and especially not for low-risk patients, but patients that are risk stratified in this way may benefit from monitoring. Thank you very much, and I'll be happy to take questions at the end of the session. Thank you.
Dr. Jamali, as always, a great presentation. You have some very difficult cases up there in Wisconsin, and very complicated ones. And it's very heartening to see how AlloSure helps even with the most difficult cases. Again, thank you. That was great. I'd like to thank all the speakers for very insightful, very exciting presentations. And now we go live for a Q&A session. Let's start. Without further ado, I'd like to start with the questions. The first is for Dr. Gupta. How does the chain of evidence presented in the ADMIRAL study change the way you use AlloSure in your practice?
So, yeah, I think the evidence is pretty interesting. And again, this is evolving data, and the analysis is not yet complete. But the suggestion is very clear that AlloSure as a cross-sectional test may not tell the whole story. And I think that was reiterated by several of the presentations during this conference. And I think it's more appropriate to think about this as a marker of injury. And therefore, there seems to be a suggestion that in selected patients, surveillance with serial cell-free DNA may be the right way to go. And in our practice, we have identified a group of patients who are at higher risk of rejection, patients who are sensitized, patients with reformed DSA, and patients of non-compliance, as well as patients with subtherapeutic control stock levels. So in those patients, we presented them for serial surveillance with cell-free DNA. And I think the suggestion clearly is that serial surveillance can pick up signals which go above and beyond cross-sectional testing, as well as above and beyond what the CEoT value is.
Great, thank you. And our next question is for Dr. Anand. Have you come across any patient cases where RCV prompted you to find an increase in injury that you may not have identified until later in the disease process?
Yes, we did have cases, especially in the sensitized individuals, where the RCV or the AlloSure at baseline was 0.4, and it jumped to 0.84 or so, not greater than 1% threshold. And we biopsied this individual and found early AMR, which was actually not seen on histology but on molecular microscope, and which has led to early intervention and treatment than we would have done usually if we would have waited either for the serum creatinine or for de novo DSA to develop. The DSA did develop, but that kind of lagged after much of diagnostic intervention was done. So yes, and now more and more we are using RCV to identify these select individual patients which are highly sensitized and to intervene early rather than late in the game.
Thank you. The final question is for Dr. Fatah. In the second case, did you see any spike in the DSA along with the increased AlloSure levels?
Hey, can everyone hear me?
Yes.
I think there are two questions. I'm not sure if we can skip the first one. Yeah, but for the second case, so basically we do not follow up with like routine series of DSAs for every non-sensitized patient after transplant. So that first one that was drawn was at the same time when her AlloSure was elevated to 5.6%. The follow-up one after the apheresis showed some reduction in her DSA burden, about 50%. Again, the first sample showed only like not borderline, it's like moderate elevation in her DSA. I'm not sure if that can answer your question.
Okay, again, I'd like to thank all the speakers for their great talks. I think this has been a very exciting session. I'm sure people have gone home with more answers than questions this time with AlloSure use, and I'm sure we'll all keep moving forward with using this in our patients and improving outcomes in our patients collectively. Again, I'd like to thank all of you and have a good afternoon or evening.